Hello, my name is Tim Siepo. I'm a family physician in Springville, New York, and a member of the faculty at the State University of New York at Buffalo School of Medicine in the Department of Family Practice. I'm here to demonstrate today what I think is a better way to examine patients, and I call it the ultrasound-assisted physical examination. This is my model today, who's Amanda Sanfilippo, who happens to be a radiology tech, kind enough to give us some of her time today. And the machine is a Biosound MyLab 30. Now, in a routine physical examination, much of it I would do the traditional way. I would look at Amanda's eyes, her ears, her mouth, and of course that wouldn't change. But I won't put you through watching me do that or listening to her heart and lungs. I would of course do that. But I'll start out here with the 522, which is a superficial linear probe with vascular capabilities. And we'll start out, if you could raise your chin, Amanda. We'll start out, and there you can see Amanda's thyroid. The echoic structure in the middle is her trachea. You see her carotid in cross-section and her internal jugular just winking at us a little bit as we go down there into the subclavians and back up again. Take some sagittal of the thyroid and of the carotid. Would you raise your chin just a little more? There's her upper carotid. There we're seeing the carotid bifurcation, and we can throw a little color on it, which will help us to pick up any stenosis, or we could put a little pulse wave. And get Doppler signals at various points. Now, ordinarily in a screening exam, I wouldn't go so far as to take true velocities, which require me to get the angle of inclination for the calculation, which in the machine uses the cosine of the angle. But you can get a lot just with the audio signal, which would be high-pitched if she had a stenosis. And just seeing if we could quickly see her vertebrals here, which we can just between the spinous processes there, although I wouldn't usually take the time to do the vertebrals. And then, sorry about your hair, Amanda. And then going to the left side, you would do similarly. Then I would ordinarily switch probes to the convex abdominal probe, which I think of as a 3.5, but this one is actually more of a 1 to 9, I think. We can go right into probe and change to what in this machine is the 431. Now we'll just lift up Amanda's shirt here a little bit. Now we're going to do a quick scan. This is not the same as a comprehensive study, but it's amazing how much you can see. There's the liver. There's her portal vein in the center. Could you take a deep breath in and hold it, Amanda? Real deep, please. There's her gallbladder coming in top of the screen. And a lot of times if you have trouble seeing the gallbladder, come over here and see the right kidney. If you just angle forward a little, you'll bring the gallbladder in again. The gallbladder can always be positively identified by a little tail on it, which is the median lobar fissure that helps you to make sure you've really got the gallbladder, and there's a pretty nice shot of the gallbladder, and not just a tangential cut of the inferior vena cava. Speaking of which, there's our inferior vena cava, and take a sniff, Amanda, like see how the inferior vena cava collapses when she sniffs, which is an indication that her right atrial pressure is less than 10. You can take a subcostal view up through the heart, into the heart. And of course, a better view this way. Now, for a true echocardiography, you usually lay the patient on his left side, and we'll try that. But you can often get enough of a view this way to quickly say that the patient has a normal left ventricular ejection fraction and does not have left ventricular hypertrophy. But go ahead and turn onto your left side for a minute, if you would, Amanda. Sit your arm up on your hip here, or above is fine. Yeah.
Tim, is it important here that we see exactly? No.
I don't think too important. Now, see, that does improve the view of the heart quite a bit. You can see her mitral valve at the bottom, the aortic valve above at the left ventricular septum. You can see that her left atrium isn't enlarged, and see that she has a nice, normal young heart. Now, if you could turn back again, Amanda. Let's get a little bit of this goop off here. Sonogoop is one of the hazards of the profession. Fortunately, it doesn't stain your clothing. And I always keep a roll of paper towels around. Take a deep breath in, again, if you would. There's her left kidney. You often have a rib shadow that bothers you with the left kidney, and you have to work around that. But you've seen enough to see that we don't have a hydro, and we have basically a normal-sized kidney. You can take measurements of it if you want. There's the spleen, just above the kidney. And coming down, we see her aorta, which is very slender. We'll go down into the pelvis. The convention is the top of the probe is either to right or superior. Let's see. Amanda gave us a little urine in the bladder, not that much, but we do see the bladder, and to our left, the uterus, and you see the endometrial stripe. Switching into transverse, you've got the uterus. I'm having a little trouble with this lighting picking out the ovaries, but you'd certainly see if there were an ovarian cyst or enlargement. And that basically is how you augment your examination with ultrasound. Now, one of the criticisms has been that the addition of the time is impractical. So let's do this exam over, this time without much talking, and let's just see how long it takes. This would be an additional to physical exam, which you're going to do traditional physical exam for whatever it's worth. Not much in many cases. Okay, we've got 338, 338.25. So we're going to go back to the neck. We're going to look at her right thyroid. Scan it carefully for nodules. We're looking at her carotid. We're going into the carotid, following it at least up to the bifurcation. Put some color on it. Do the same on the other side. Thyroid. Isthmus. Carotid. We're going to switch probes. Go to the 431. Go into the abdomen. Look at the liver. Take a deep breath in, if you would, Amanda, and hold it. Get her gallbladder. Okay, thank you. Give me one more deep breath, if you would. Get her bile ducts. Take another deep breath in, if you would. Get her right kidney. Okay. Look at her inferior vena cava. Take a sniff. Look at her left kidney. Take a deep breath in, if you would. And her spleen. We're going to take a quick look at her heart. Let's turn over again, Amanda. That was a lot better in your case. Nice parasternal long axis view. Good contractility, no LVH. Turn back if you would. Well, we're going to try to see her aorta again. And down into the pelvis. Start out in sag, find the bladder, find the uterus. Turn into transverse. See if you can find the ovaries. So the whole thing, quick scan, well, I've got 43:30, what did I say, 38, I guess that's 5 minutes. So it does take a little time, but you get a lot of information. Ultrasound is very useful in general practice in evaluation of patients with musculoskeletal complaints. As you know, we see many patients with painful shoulder, painful wrist, painful elbow, painful knee. And let's start with examination of the shoulder. There's Amanda's acromioclavicular joint, looking, nice and smooth on both sides. Good, put your arm behind your back, Amanda. There's her rotator cuff, looking like an eagle's beak. She has a nice stout supraspinatus muscle there. And switching into transverse on it, get that kind of tire look, I call it. But you can scan back. Some of the small partial tears are not that easily seen, but you can also inject some saline in the joint and do a kind of a saline arthrogram, and you can see the black fluid come right up into the tear, which are usually on the underside of the tendon. So that's very helpful in evaluation of shoulder problems. Okay. The wrist, you can look for effusions. You can look for carpal tunnel syndrome. The ultrasound diagnosis of carpal tunnel is said to be as good as that on the EMG. Could you wiggle your index finger? There's her, right above her wiggling tendon, you see her median nerve with the little nerve fibers. And we could take a cross-sectional area of that carpal tunnel, which is how you diagnose it. Beyond that, you can look at any lumps and bumps, see if she has any, ganglions or effusions. In the knee, you can't do too much, but it's very helpful to see if there's an effusion, and you can detect very small effusions. There you see Amanda's knee joint, and you see the white triangle going down into the joint. That's the medial meniscus. And here, of course, is her quadriceps tendon going up onto her patella, and her patellar tendon. And you can see her infrapatellar fat pad, and you could see if she had an infrapatellar bursitis, which you don't, Amanda. There again is her extensor mechanism. Now, if you could roll over, Amanda, roll right over on your stomach, if you will. Now, this, of course, is the other knee, but commonly you see the Baker's cyst, and the Baker's cyst occurs between the medial head of the gastrocnemius and the semimembranosus as it crosses there. So you just follow her medial head of her gastroc up, and there's her knee joint. And there's the crossing semimembranosus, and there's no Baker's cyst. And there's her popliteal vessels. But that isn't the way we would usually see the vessels. And of course, commonly in the office, you'd like to rule out a DVT. Could you roll back, Amanda? Now the patient for venous study is usually externally rotates and abducts her hip, and you go up into the thigh and find your vessels. There we go. I was just pressing too hard. You see the femoral artery, and winking below it, you see the femoral vein. And commonly, you just follow that down in cross-section, which is the easy way not to lose track of it. Just making it wink as you go. Of course, most of the serious DVTs are in the thigh. So if you can see the thigh down through the adductor canal, you can be pretty sure most of the time that you don't have a DVT for a quick study. And it gets a little harder as you get into Hunter's Canal. But with a little patience, you can do it. Down into the popliteal. Now the vein is on top. And you can follow it down into the posterior tibial and peroneal. So that's the fibula there, that's the tibia there. And you can make those wink, and that's, quick DVT study, which is often enough, or if you want to take the time to do a comprehensive study, or refer the patient if you don't have the time. And of course, it's nice to look at Achilles tendon. And you can pick up tears or calcific tendonitis. In the Achilles. So there's a lot of things you can do in musculoskeletal and vascular, and you can follow your arterial tree down, much as we did the venous in cases of suspected arterial insufficiency, in addition to getting your leg blood pressures. Physical examination, as we were taught it in medical school, it has so much respect, and there's so much tradition behind it, and the hands-on approach, touching the patient, and all of these techniques we were taught in school. Palpation of thyroid glands, percussion of the left cardiac border, looking for the succussion splash of ascites, bimanual examination. It's all so nice and traditional, and it has so much honor and respect connected with it, but really in modern times it's not very good. It's been shown that you can't feel thyroid nodules with anywhere near the accuracy or frequency that ultrasound can find them. Carotid stenosis, not very accessible. Most of the severe stenoses don't have carotid bruits, and you won't find them that way. In the heart, the stethoscope, I mean, it's nice. I still carry it, but it doesn't tell me anything about the patient's left ventricular ejection fraction or whether he has LVH. It tells about valves to an extent with murmurs, and yet many of the loudest murmurs are from trivial valve leakages, and some of the most severely stenotic valves produce almost no sound at all. In the abdomen, particularly today with so many obese patients, how valuable is palpation of the abdomen? Many times, I confess, I can't feel anything in these big people. Likewise in women, bimanual exam. So really, we all need to teach physical examination. We all need to learn it. But it's pretty outmoded today compared with what you can do with the ultrasound-assisted physical examination. I hope you'll consider adding ultrasound to your examination. Thanks for your attention.